Thanks, Dr. Owen. Is Dr. Joyner,
Yes, sir. I'm here. Hello.
would you like to announce the executive committee's decision, Dr. Joyner?
Yes, I will. Thank you. The executive committee met and after discussion has voted to recommend to the full board approval of your application for a permanent license.
Thanks. Thank you. Thank you, Dr. Joyner. And at this time,
Dr. Cleveland, in the event that the board has any questions about that, did he have the option to stay if he wanted to for at least that portion?
He got 2 broken hips last night.
All righty, no worries. Well, okay. That's it. Well, the hips win.
we can call him.
We think we can get him on the phone call.
And just tell him that, yeah, see if you can, just in case. I just didn't want to, I wanted him to be able to have that ability to speak to anybody, should that be necessary.
I'm going to turn the meeting over to our esteemed president, Dr. Joyner. I mean, Dr. Owens, sorry.
So I'm president now.
Congratulations, Dr. Joyner.
Thank you.
We're here at your service. All right, we are now moving on to the second item on our agenda, which is a Zoom appearance by Dr. Theodore Feldman. And Dr. Feldman, I think I have noticed here that he is also accompanied by legal counsel, Brian Higgins and Marty Kate McNulty, so 2 lawyers. Does that sound right?
No, Dr. Owens, it's just me, Brian Higgins. I'll be representing. Okay. Yep.
All right. There are 2 people on my list. Okay. And so, and I think also Dr. Randall Curnow.
Correct.
Okay. Who's also listed as medical director. And so it states that the reason for this appearance is a request of a waiver for the 2080 and 75-mile exceptions. Okay.
That's correct. Yeah, and I can provide an overview for the board to just sort of set the stage and what's happened here in the past. Dr. Feldman's previously been granted these exemptions, and we're requesting to add an additional APRN under that supervision, and we're asking Dr.
Is Dr. Feldman here?
I am.
Okay.
I'm right here.
Can
I would ask, yeah, I'm sorry. If
That's
Mr.
okay.
Higgins could
Can we hear
just
from
present
our
an
licensee first?
Oh, sure.
That's
Good.
we typically would prefer to hear from the licensee first.
Okay.
Okay.
Good morning, everyone. Thanks for the opportunity to appear before you. This is my second opportunity, and I appreciate having been granted this request in the past. A quick update on kind of what's happened since the last time, and then we can maybe get into the request. But we applied for this, and Mr. Higgins can give you the exact dates, and I'm sure it's before the board. We now have been operating as an RPM company, which has nurse practitioner care delivery, a tech platform, and the remote monitoring capabilities of blood pressure cuffs, scales, and glucose monitors to manage diabetes, hypertension, congestive heart failure. In the state of Mississippi now, we have 4 sites. We've seen since our last meeting before the board 1,672 patients among 37 providers. At the present time, Cadence has been operating in about 25 states. We have now serviced since our inception over 40,000 patients. We're actively involved with 8 health systems, with another about 7 large national health systems already contracted and beginning. Our average age of the patient is 74 years old. And I remind everyone that the state of Mississippi is a state from a public health perspective that's got a lot of challenge in the disease entities of diabetes, hypertension, and heart failure. As an example, about 15% of Mississippians are diabetic, 44% hypertensive, with over 1 million hypertensive patients in the state of Mississippi, with about 11% increase over the past decade. And unfortunately also has the highest mortality of any state in the country of congestive heart failure. These are particularly the disease entities that Cadence has been working with. And just to summarize on a national scale now, and these are published results in peer-reviewed journals, we have a 27% reduction in hospital admissions in over 6,000 patients reported, about a 30 to 35% reduction in hospital admissions for people with congestive heart failure at a 6-month interval, which is a critical interval. About 70% of hypertensive patients now, and almost 24,000 patients reported, have blood pressure controlled to national guidelines. And 43% of our type 2 diabetics nationwide have A1Cs below 7, which is considered excellent control. We are compiling this data for the 4 sites in Mississippi, but believe them to be both part of the national data bank that I just reported and consistent with that. So today, the request is to be able to add an additional nurse practitioner, add Dr. Curnow as our medical director. I'm a cardiologist by training, seeing patients today in South Florida. Dr. Curnow is a board-certified internist with extensive experience both in the management of these conditions as well as in the quality assurance and leadership that he's provided to the National Council on Quality Assurance, and he can comment on that. So I think we're here to just be able to continue to help the people in the state of Mississippi with the type of, I believe, excellent work that we've been able to do at very high quality and at really minimal additional risk. So that's our request today. And I would ask the board for that permission and the opportunity for Mr. Higgins to maybe offer some additional color that I've not been able to provide. So thank you very much.
Yes, that was a great overview. I just want to add to, just for the board's consideration, we are, and this is probably the most significant factor, is we do not supplant Mississippi-based and licensed physicians. We are a bolt-on service to these providers. So we're only able to care for Mississippi-based and licensed physicians and their patients if those physicians order our services, which is based on their own determination that remote monitoring would be helpful and medically necessary for their patients for our specific disease states. I will let Dr. Curnow also introduce himself in a moment, but yes, we are asking that Dr. Curnow be granted the same exceptions that this board has already granted to Dr. Feldman in May of 2023. We have seen a significant uptake by Mississippi-based and licensed physicians that we work with. We work with the Merit Health Medical Group in 4 different markets. We have 1,672 patients right now that we are currently monitoring. And we're just trying to anticipate future buildup and more patients that we will be monitoring and working with these Mississippi-based and licensed physicians in the Merit Health market and also beyond. So again, asking for Dr. Curnow to be granted exemptions to those same rules. And we would also ask the board to allow Dr. Feldman and Dr. Curnow, should they grant the exemptions before them today, that our physicians also be able to supervise up to 8 APRNs moving forward into the future, and also that these exemptions apply outside of the Merit Health Medical Group in Mississippi to other medical groups that we might work with in the future. Obviously, if the board wants us to come back and present on those, we're happy to do so, but just wanted to offer those up for consideration as well.
And just to introduce myself, I am privileged to be here before the esteemed board today, and it's our honor to serve as an organization. Mississippi licensed physicians who practice in Mississippi and their patients who live in Mississippi. As Mr. Higgins noted, we do not supplant, we support actively practicing physicians in Mississippi and are simply a bolt-on service and a virtual extension of their practice to give providers and patients the resources and access to continue monitoring. We educate patients. with strict protocols that were discussed in the board meeting when Dr. Feldman was initially approved. Strict protocols which were approved by the health systems and the individual providers using our services. We help educate, monitor, support, and when needed, titrate medications on behalf of the chronic disease state, which Dr. Feldman eloquently mentioned. I'm Cadence's medical director. I've been a primary care internist for over 25 years. As Dr. Feldman also mentioned, I'm the chairperson of the National Committee for Quality Assurance's Clinical Programs Committee. I take quality and transparency and governance very seriously, and it's a privilege to be here today. I'm looking for having exemptions for the 75-mile and the 80-hour rule, as Dr. Feldman was granted 2 years ago. And also, as Mr. Higgins noted, the extending to 8 APPs and also extending beyond the merit system so we can continue to add value to the providers that work in Mississippi and their patients.
So thank you for that. Can you tell me a little bit more about your background? What's your clinical practice or your clinical activity like today? And I appreciate Mr. Higgins' requests and his overview, but as a regulatory agency, the questions that are being placed before our boards are really dealing with licensure and licensees and with waivers related to our rules and regulations that currently, for whatever reason, don't meet. And so I just wanted, when I asked to hear from licensees, it's because those are the things that really matter to us, is learning more about you and about what you do and the services that you provide, and in the context of why that would justify an exception to our rules. And so that's kind of why I always like to hear from the licensees first, because this board is really focused on protection of the public, but we do that through regulation of licensees. And so to me, that's the most important thing first and foremost. And I have much respect for lawyers in the legal profession and the work that they provide when it comes to entities in healthcare, and they're great partners. But really I think where the rubber meets the road is really hearing from the docs, because you guys are the ones that we're entrusting the care of patients in Mississippi to. And so ultimately, that's the thing that to me rings the loudest. I don't know if that's the same for all of my other fellow executive committee members, but that's kind of why the order is as I requested.
Well, it's certainly my pleasure to be able to answer any questions. And basically, I am a primary care internist. I have been a practicing primary care internist since I graduated from my residency program in 1997. I have been a full-time practicing primary care doctor about 75% of my career. Other parts of my career, I've been part-time administrator. I have been the chief medical officer of a few large healthcare systems, one in Ohio, and run a few accountable care organizations where in those roles, I was a part-time practitioner. I was last a full-time practitioner 3 years ago. And over the last 3 years, since I've been medical director of Cadence, I have been directly involved in patient care, supporting the protocol-driven processes and not only supporting our care plan and supporting our RNs and licensed nurse practitioners who are licensed in every state we practice, but also conducting, also with Dr. Feldman, the quality audits and making sure the regulatory processes to ensure quality of care is undertaken in a way that's suitable for the great state of Mississippi and the other states we work for.
So how much of your time right now is being spent in clinical care, direct clinical care? Not the direct involvement through support, but how much of it is like direct patient care?
Yeah, I do not see patients privately on my own over the last 3 years. I am a clinical support physician since my time in Cadence, beginning in late 2022.
Thank you. Any other questions? Dr. Lippincott, I saw you hit your mic.
Thanks, Dr. Owens. I missed the numbers. How many Mississippi patients are y'all monitoring now?
1,672 patients at 4 Merit Health sites representing the referral of 37 Mississippi licensed physician providers.
Thank you. I don't have any other questions right now.
Dr. Joyner, do you have any questions?
Yes, right now your practice is restricted to Merit Health, is that correct?
Yes, sir.
Uh, uh, Paul, are we restricting them to Merit Health, or are they just restricting because that's where their practice is?
They've requested to be opened up to other referring physicians as well.
Okay, they requested, did we grant it?
That request is before us right now.
Okay. The other thing, I think, Dr. Curnow, after looking at the plethora of information we've had over the past 2 days, you get kind of punch drunk. You're located presently in Miami, or am I wrong on that?
I'm in Miami, sir.
You're in Miami.
50-50 shot, Dr. Joyner, of getting that right. Almost had it.
Where are
I'm
you
in Cincinnati.
located?
I'm in Cincinnati, Ohio.
Cincinnati. And Dr. Gardella, you're, okay, I got less than a 50-50 shot here. Arkansas, is that correct? Christina Gardella?
Oh, hi.
Hi.
So I'm not the representing NP. I'm the compliance person for Cadence. But yes, the nurse that we're looking to add to Dr. Kernow's exemption, they would be in Arkansas.
Okay. I just found it interesting that none of the individuals that we're looking at are located anywhere in Mississippi, but being remote monitoring, I don't have a problem with that. So I really don't have any other questions.
So I have a follow-up just for general information. So as you mentioned, Dr. Feldman, early in your presentation about some of the barriers and challenges for a state like Mississippi, where a lot of our population is rural, and there are challenges that go along with that. What has been your experience over the past couple of years that you guys have had a presence within the state? What's been your experience with barriers for you being able to render care? Because the reason I asked that question is because RPM is one of the things that we think about as facilitating access to care. But I think theoretically that is true, but there are definitely some, when you try to put it into practice, there are definitely barriers that exist to being able to do that. So what's your experience been as a group that came in a couple of years ago and has been able to kind of build or establish yourselves here? What's that been like for you?
Yeah, I think that's a great question. I'll just rewind a little bit to sometime last year in front of the congressional U.S. House Ways and Means Committee under, I think it was Representative Comer, but our Chief Executive Officer, Chris Holchick, and our now present Chief Medical Officer, Evie Cunningham, who was at the time the Chief Medical Officer of Provident Health System, which was one of Cadence's partners, was asked to testify about impending codes for RPM as they related to RHCs, rural health clinics, and FQHCs, federally qualified health clinics, which are more inner city and urban, around the importance of RPM to improve access in both of those sites. And I think what we found at that point, and I think the reason the Ways and Means Committee was so interested in hearing about it, is that the future of RHCs and FQHCs is to a large degree dependent upon RPM to improve access. And our experience in the state of Mississippi is really no different than our experience all over the country, where about 75 or 80% of our enrollees would qualify in RHCs or FQHCs. And thereby, that experience is that as a result of this, we are really significantly able to improve access to specialists and primary care doctors in these venues. I'll share with you a simple fact. 2,500 of the 5,000 counties, or 50% of the counties in the United States don't have a board certified cardiologist within that state. Our ability to provide both primary care and specialty care in the state of Mississippi really parallels our experience all over the rest of the country, is that we're dramatically improving access. Our NPS for patients, meaning on a scale of -100 to +100, would they recommend this to a loved one, a family, or a friend? This service, we have NPS scores in the 50, 60, 70 range, which even exceeds Apple, which as a commercial plan has often one of the highest NPS. So I think one of the most important things we're doing for folks in the state of Mississippi, as well as around the country, is improving access in rural health clinics primarily, and also now more and more in federally qualified inner city health clinics. So it's been consistent, it's important, and I think to a large degree, one of the reasons that CMS has continued to fund this and expanded into other codes like advanced primary care medicine and chronic care management is to improve access in rural America, where we know that part of the limitations of improving healthcare in states that are largely rural is access.
Yeah, and I'll just add to I'm not as eloquent as Dr. Feldman, but just to add a couple just technical facts. Our program is actually created to facilitate rural access. We don't require Wi-Fi. We don't require our patients to log into some kind of app. We use cell carriers. The chips are built into the devices. They don't have to do anything, and whatever cell reception they have automatically links to them. So we've published data showing that we've compared rural communities to urban and suburban communities, and we've actually proven that care is equivalent for those patients. And that's unusual given the fact the access problems and the care access challenges that they have. And we're able to bring equivalency based on our technology, which really helps level the playing field. And we're very excited to be able to do that in the state of Mississippi and hope to be able to extend that further.
Yeah, thanks. That actually is really helpful because I don't know that it was really intuitive. When you think remote monitoring, I think a lot of us immediately go to like Wi-Fi or internet based, and we still have issues with broadband access and those kinds of things. So that was kind of one of the specific things in my head that I was thinking when I asked that question, just kind of how it was working for you all, because we do know that there are many places throughout our state that still have difficulties with that.
Yeah,
So
and-
thank you for that.
No problem. And in odd cases, we do have boosters that patients can use to help boost their cell signal. And we've been serving rural communities in Mississippi, Appalachia, in North Carolina and Tennessee, same problem. So this is a ubiquitous issue that the country's struggling with. And as Dr. Phil mentioned, the Ways and Means Committee is one of the reasons why Cadence in particular is a leader in this, because we really do need to help use remote monitoring to level the playing field for the providers and the patients in the state of Mississippi and beyond.
So gentlemen of the executive committee, do you have any additional questions?
No, I don't.
Hearing none, I'm willing to entertain a motion at this time. Don't everybody speak at once.
I move that we approve the request for all three.
It's been moved and seconded that we approve. Now, when you say all three, I need you to specifically state what you mean by all three, because that was a little general for the record.
I'm sorry, Dr. Curnow, I approve him for medical director. And I don't have right in front of me on my fingertips the name of the nurse practitioner. Does anybody have that?
We're approving
These are the two requests for exemptions.
yeah, two requests for exemptions. Dr. Feldman and Dr. Curnow we're voting to approve the exceptions to the 2080 and the 75-mile rule for Dr. Feldman and Dr. Curnow.
And the additional request to be able to accept from outside of Merit Health, referrals from outside of Merit Health.
Did our, and just to get, our initial was limited
It was,
to,
that
or
wasn't on
was
the
not?
initial request. That was made by the attorney during his presentation.
To limit it to merit?
It's limited to Merit. Currently, they're asking to
That's-
expand beyond Merit.
Is it limited by us?
That was my
Yes.
question. We were the ones who limited it.
That was the original
That's what I
request.
thought.
Yeah.
Okay. So we have a motion.
You can't run the meeting and not run the meeting. What are you gonna do? You gonna run the meeting?
Refer to our esteemed president. I'm just trying to figure out what's going on. I'm thinking out loud.
Oh, my goodness.
And I believe the request also includes increasing to 8 APPs per
So-
provider.
So we have a motion on the floor right now. And so we're trying to clarify what that motion is. So again, the request that we have, because the written request for multiple MPs is not included on the paperwork that I have in front of me. So I'm going with the information that was submitted for consideration to the executive committee. And that basically is the exception to the 2080 rule and the 75-mile exception. And so that takes care of two. And Dr. Joyner, the third item that you were referring to is which one? Is that going to be to extend outside of the Merit Health System?
Yes.
Is that the third that you were making reference to? I just want to clarify what the
Well,
motion.
yeah, I was making reference to that.
Okay.
That was in my questioning. And the other was, aren't we adding a nurse practitioner?
That's correct.
Okay.
So then, Dr. Joyner, could you please, so just for clarification, your motion would be to approve the request for the two waivers for the 2080 and 75-mile, and to extend outside of Merit Health System, and to approve the addition of the APRNs that have been submitted for additional, to be added to the current list. Is that correct?
Yeah.
Okay, we got that, everybody. Dr. Lippincott, that is the motion in its entirety.
I second that motion.
All right. So you've now heard the motion. Is there any discussion? Joyner, rationale for extending outside of Merit based on the decision to do so before?
I'm sorry.
I just said, so, I just was asking you what your rationale is to move this outside of the Merit Health System
Well, I
based
think
on,
number
based
one
on
is-
the rationale before. Anything different or new that would justify that move?
Yeah, Merit, of course, is in our state. Me being a patient in the system right now, I realize that I go to more than one hospital. In fact, I go to every hospital in Jackson, Mississippi. So whether or not we like it, those patients that go to Merit are going to go to Baptist, are going to go to St. D's, are going to go to hospitals on the coast. And I don't know if you can, you know, if you're going to monitor for Merit, you're going to also monitor for the others if they request it. I wouldn't have any problem with that.
Dr. Lippincott, any further discussion?
No, thank you.
All right, it's time for a vote. So all those in favor of the motion as stated, which includes extension outside of Merit, the addition of the nurse practitioners that were submitted by request, and the exemption, the addition of Dr. Curnow and exemption of the 2080 rule and 75-mile rule. All in favor, say aye.
Aye.
Aye. All right. We have it.
Thank you
very
so much.
Thank you
We're
so
very appreciative. Honored to serve the people of Mississippi. Thank you.
Thank you.
So just before y'all go, just so you know, that'll be the recommendation to the full board. Okay, so.
Thank you.
Thank you, gentlemen.
Thank you.
Thank you.
You get all that, Francis?
We can go back and watch the film.
All right, next item on our agenda is, I think it's the appearance of, make sure I got everything together. Is it Dr. Guarisco?
Yes, exactly.
Dr. Guarisco, license number 23638. And so we can, Dr. Guarisco, oh, hello, hey there.
Hey,
Thanks for being with us and for being patient through our morning. So why don't we just go ahead and let you tell the board what your request is, how we might be able to help you today.
okay. Well, I'm looking for licensure in Mississippi again. I was licensed once before. So I'll just go back. I was one of the first board certified emergency physicians in Louisiana back in 1980 from the first residency class out of Charity Hospital. I practiced at Ochsner for 40 years, actually 39.5 years. Could not quite make 40. I was board certified in 80, 90, 2000, 2010, and in 2020, I did not complete board certification for a few reasons I can go into. But during that time and since 2020, I am now the medical director for a company called International SOS, and I provide medical services for SpaceX, NASA, Amazon, the airlines, oil and gas through out the Gulf of Mississippi, Gulf of Mexico, or Gulf of America. I provide remote support for Netflix and different corporations. So anyway, not getting board certified in 2020 was one of the greatest mistakes of my life. Clearly, I'm happy to go into those reasons why it didn't happen. But my current position now with International SOS, I have drill ships in the Gulf of Mexico. And sometimes these drill ships, most of the time they're in international waters. Occasionally they slide into state waters outside Louisiana, Mississippi. And it's important for me to be licensed in those states if they're in state waters. Occasionally I have to medevac a patient into Mississippi to a trauma center or to a burn center, to a specialized hand surgeon that we have relationships with. So it's just important for me to be licensed in Mississippi. I don't see patients in Mississippi. I don't have a practice in Mississippi. It's strictly for those instances when I venture into Mississippi state waters or in Gulfport, if we'd have a drill ship in Gulfport. And my licensure in Mississippi would be really helpful in managing those patients for a short period of time. So it's, that sort of generates the issues, the need for this license in Mississippi. I've never no malpractice in 45 years of practice, not a single malpractice case. I've had the highest patient experience. When I ran Hancock Hospital in Bay St. Louis area, we did a great job in putting that ER together. So my work in Mississippi, I thought was stellar. Again, I haven't had a single clinical or complaint issue in all my years of practice. And I wish I could go back and get that board certification in 2020. But I just have a singular isolated need to be able to take care of patients when these drill ships venture into Mississippi waters. At some point, there could be other industries in Mississippi. I just got licensed in Nevada by endorsement for a lithium mine in northern Nevada. Same thing. I have a medic in northern Nevada that I need to manage clinically at times. So again, it's a very isolated, very narrow case for licensure in Mississippi, but it's It's really important to me to be able to be there for my patients. I can answer any questions, but that's sort of the,
Okay, at this time, I will open the floor to questions for Dr. Gorisko.
yeah, please, thank you.
Good morning, Dr. Grisco.
Yeah.
I'm Ken Lippincott. I'm a psychiatrist from Tupelo. But anyway, so you're requesting an exception to the requirements, which I understand you had some complications back in 2020, which is why you did not get recertified and reboard certified. Is that correct?
Yes, I'm happy to talk about those.
Yeah. Tell us were you planning on getting recertified? What happened?
Yeah, I was, in sometime in 2019, my son was a marathon runner and I used to run with him. I severely damaged my knee, I guess, in the just overuse, developed a severe knee problem. I went to work every day anyway, but Dr. Derek Jones at the Sports Center in New Orleans operated on me. I had a knee complication that didn't resolve until late 2019. And I just decided it was a good time to retire from Ochsner after 40 years. I was looking for other things to do. And then COVID hit. COVID was another interruption in my life, everyone's life. I just didn't get board certified, and I should have just pursued it. I don't know. I just didn't think.
And when did you take the specs?
I tell you, I took the specs 3 times in the last 18 months, and I scored 74 out of 75. And the specs was interesting. I actually studied for the last time. The content in the specs was OB, a lot of pediatric neonatology, pediatric endocrinology. It tested nothing of what I trained for in my residency or in my experience as a full-time emergency physician, and tested nothing about what I do now. It was it was a difficult test. And when I took the test, it was in no way reflective or tested what I trained, how I trained, what I trained, the content. It was difficult, difficult test. It doesn't measure anything about my training or my current knowledge.
Okay, thank you. And how many states are you licensed in now?
You know, I think it's probably 23, 24 states, 25 states.
Okay.
It's a full-time job.
I just would like to mention that in 1980, I spent some time down there where you were. I started a residency in psychiatry and neurology there at Tulane, and that was the first emergency medicine residency class. Is that correct?
Yes, it started in 78, and we were not accredited when we first started the program, but it was accredited at the end. And I might just mention, one of my goals at Ochsner was to make sure I created an emergency medicine residency program before I left. And in late 2019, the American boards granted us a residency at Ochsner. So that was one of the reasons I left Ochsner, because I completed my goal of creating a training program and moving on to other things in life. Yeah.
I bet you spent a lot of time in the accident room and the West Admit emergency room.
Yeah, room 4, if you remember, room 4 at Charity. Yeah, room 4 at Charity was the ER, was the Center of Emergency Medicine outside of Cincinnati in 1980. Yeah, it was.
Okay, thank you. I don't have any further questions right now.
Dr. Joyner?
Hello, Dr. Joyner.
Yeah, I got two, and good morning. I got too many buttons on this computer to mash. I don't have any questions at present.
Sure, Dr. Cleveland.
Dr. Gorisko, my name's Ken Cleveland. I'm the executive director here at the medical board.
Yeah.
Are you still board eligible?
I haven't explored that. It's possible I am. I'd have to discuss that with the American board. I've thought about that recently, if that would still be board eligible.
That would be the exam that's in your, consistent with your training, right? If you're
Yes.
board eligible, you could still take the boards.
Yeah,
that
but I
you're
may not
training.
be. I have a feeling, I think, I might, that window may have expired. I think there's a 3-year window after 2020, so it may have expired, but that would be the test that would measure my competency. The specs does not. Yeah, I agree. But I practice good medicine. I take care of critical issues every day. Whether they're disasters at SpaceX recoveries or in-flight emergencies or chest pains in the Gulf of Mexico, I do very, very good work. I trained well and I stay clinically relevant.
So Dr. Gorisco, just so that I want to make sure that I'm fully understanding what the request is centered around, um, just the provision of care for those people who are offshore, who occasionally fall under the jurisdiction of the state of Mississippi.
Yes.
Um, and the care that you are providing now, you're not out on rigs or skiffs or anything like that. Like what are you, is it remote work? Like what exactly is the
Yeah, good. Great question. So I have a what's called a response center. So in Baton Rouge, I have a response center that is staffed by 2 licensed nurse practitioners. So those calls from say a drill ship in the Gulf of Mexico, those calls come from the medic to the nurse practitioner, and the nurse practitioner escalates the care management to me. And so I'll manage that case remotely. So I don't actually, yeah, it's remote medicine. It's not really telemedicine.
okay?
It is direct clinical management of these patients.
I got you. So it's really telehealth or remote work. Got it.
Yeah, yes.
I just wanted to make sure that was what I thought, but I wanted to make sure that that was explicitly stated. I wasn't mistaken there.
That would be consistent with what we call tele-emergency medicine, with our hubs and outlying ERs. So
Yeah, there aren't many occasions where these ships, in international waters, any state license is valid for international waters, but in state waters, it's really important to have a state license just to be compliant. I don't want to be directing patient care without a Mississippi state license. It's not a frequent occurrence, but that's really my use need is in those instances.
Thank you for that clarification.
Yes, thank you.
Any other questions from the members of the executive committee? Hearing none, I will entertain a motion.
I move that we exit current session in order to enter into executive session to discuss this matter.
I'll second that.
So it's been moved and properly seconded that we close the meeting to consider whether to enter into executive session on this matter. All in favor?
Aye.
Aye. All right. Meeting's closed. We have, oh, there you go. Dr. Grisco, we were wondering if you were back with us. Okay. So we are back in open session. And one of my esteemed colleagues will give the decision of the executive committee.
Um,
That would be Dr. Lippincott.
I'm Dr. Lippincott. Anyway, the decision of the executive committee is to recommend that the board approve his request for licensure, to approve his application. Exemption to the rule for his application. Yes.
Which means
Thank you.
Yes.
Thank you very
thank you.
much for your time and for the work that you're doing. It's greatly appreciated. That the folks who work out in the Gulf are there are lots that creates a lot of stability for many families in our state, and so it's a big part of economic stability for the patients in Mississippi, and those guys out there need good care. Guys and girls out there need good care. So
Yeah, I
thank you.
appreciate that. Many of the employees in the Gulf are citizens of Mississippi and Louisiana. Yes, absolutely. I appreciate that greatly.
Awesome. Thank you so much for your time.
Okay. Thank you. Thank you, committee.
All right. So that concludes all of our appearances. At this time, we'll have our executive director's report. Not the fancy formal one, but just the informal.
The informal EC version.
The EC version. Yeah, the mini version. The maxi version comes next.
All right, thank you. So I've changed a little bit on how I've been thinking about this, on how I want to do this. So in the past, and in the formal executive director's report at the board will still fall into this category. When I'm reporting in March, I have reported for January, February. Okay, and the results of January, February. For this more informal executive director's report, I'm going to start reporting from the end of the last board meeting to the start of this board meeting. Does that kind of make sense? So it includes the first part of March.
Yes.
Okay. So just I continue to meet monthly with the other health boards. Y'all are familiar with that. I think at this point, the director to director breakfast, which includes nursing, dental, pharmacy, health department, and ourselves, continue to meet monthly with our physicians health program to review any potential issues that could arise there. I didn't get a specific count. I was on how many different licensees I met with for potential violations of the rules and that just needed a little corrective course action. This year, as a reminder, I'm the vice chairman of the IMLCC, the Interstate Medical Licensure Compact. We started a new meeting of just the officers that plans out an agenda for the IMLCC for the next year. And so I attended that. That was a 2-day meeting. Attended a Federation of State Medical Boards meeting. I'm a board member for FSMB now.
You're so good. You're such a great executive director.
I'm patting myself on the back a little bit here. Y'all give me the opportunity to do it, I'm going to do it, right? I'm going to try not to break my arm doing it.
Look at our executive director.
I was invited to speak along with Phyllis Johnson and Susan, for whatever reason.
Board of Pharmacy.
Board of Pharmacy, yeah. McCoy,
Then it starts
Susan
with an
McCoy.
M. I was like, it starts with an M.
Phyllis, Susan, and I presented to the North Carolina Board of Pharmacy Compounding Summit. They specifically wanted us to address how we investigate IV hydration stations and what that has led to. And then for the first time since I've been here, earlier this week, it was either late last week or earlier this week, I hosted an investigation collaboration meeting with federal, state, and local agencies all involved, working together on a investigation. So, and it was a very good, productive meeting. So anyway, that's where we are currently.
Awesome. legislative session.
Yeah, so, and this will be in the formal report to the full board as well, but as I notified y'all earlier, we did make it out of the Senate this year, and we were double referred on the House side. We made it out of one committee, but not the other committee. So technically, we died in committee with our Medical Practice Act update. And we expect at this point, the feedback we're getting is that we will get full funding of our request as far as money goes and as far as positions go. We're trying to add two new positions. We're trying to add second attorney along with Paul, and a for lack of a better word, a social media person. I can't remember the exact title that person will carry.
Communication.
A communications director. Thank
There
you. So yeah, so that's
I mean, Paul didn't need any help. He's
Nah.
killing it. He don't need any
Yeah.
help.
there's nothing going on here that we would ever need a second attorney for, right? Yeah.
No, thanks so much, Ken. And just being a little lighthearted because you guys, I mean, everybody's doing so much hard work, and I can't say enough about how great the staff is doing, and how much all the support that we can get for you guys is definitely warranted because you're doing a yeoman's job or a yeowoman's job, depending on what your gender is and how you feel about that. So, all right. Well, anything else? Any questions, comments? Of course. Dr. Lippincott.
Medical Practice Act die in the House Committee.
The second committee, we were double referred, made it out of one committee, didn't make it out of the second committee.
In the House.
Yes, sir.
Senate passed it.
Senate passed it. We made it out of the Senate. It was transmitted over to the House. And then, so it's a long convoluted story. There was a version in the House that actually passed out and was sent over to the Senate. That died on the Senate side in committee. The version that was sent out of the Senate to the House side died in committee. So, yeah.
Awesome. All right. Well, hearing nothing else, we will go ahead and adjourn this meeting of the executive committee and be ready to convene with the full board. We're a little bit behind, but not by much. So hopefully we'll be able to resume. I'll give everybody 7 minutes to get situated. So by 10:10. Thank you.